Hello, everyone, and welcome to another installment of ClearPoint's on-demand webinar series. We're honored to have Dr. Paul Larson here with us today to discuss the importance of MRI guidance for direct intraparenchymal convection-enhanced delivery of gene therapies. We have dedicated some time at the end of today's webinar for a Q&A, so please utilize the chat function to submit your questions at any time throughout the presentation. We'll do our best to get through all of the questions in a allotted time. However, if we're unable to get to yours, we'll make sure to have someone follow up with you afterwards. With that, please join me in welcoming today's speaker, Dr. Paul Larson. Dr. Larson completed medical school at the University of Arizona in 1995, followed by his residency and training at the University of Louisville. He has been a professor in neurological surgery at the University of California, San Francisco from 2001 to 2021, and has recently returned to Tucson, Arizona, where he is currently a professor of neurosurgery at the University of Arizona and the chief of neurosurgery at Southern Arizona VA healthcare system. Dr. Larson is what one might call a pioneer in the field of MRI-guided surgery, as well as clinical trials for neurodegenerative disorders using gene therapy. He has performed over 1,000 MRI-guided procedures and even wrote the book on interventional MRI-guided DBS, literally. With regards to gene therapy research, Dr. Larson and his research team have either been the solo group or lead group in 10 gene therapy clinical research trials since 2004. Dr. Larson, thank you so much for being with us today. Without further delay, I'll now pass it on to you.
Great. Thanks, Cameron. Very kind of you. This is content that I've prepared, and I've been compensated by ClearPoint Neuro to do this today. Here are my other financial disclosures, and we'll get going. So we've predominantly been focused when we think about biologic therapies for brain disorders on neurodegenerative disorders. And for good reason. There are about 30 million people in the world that suffer from a neurodegenerative disorder. And we currently have no disease-modifying treatments for these patients. So when we talk about biologic modulation, there are really two things that we're talking about. One is cell transplantation, and the other is gene therapy. And we're going to focus primarily today on gene therapy because that is the lion's share of what has been done so far and what the field has been focused on. Although there are a lot of these principles that can be applied to cell transplantation as well. And so gene therapy is a method where we use a virus, a viral vector specifically, to deliver a gene of interest to a particular brain target. And there are several strategies that we can employ. We can try to replace an enzyme that's deficient. We can deliver a growth factor to try to stop or slow degeneration of part of the brain. In the case of something like Huntington's disease, we can try to disrupt the production of an abnormal protein. And the target and the therapeutic strategy depends on the particular disease state that we're trying to affect. And the human trials so far, this is a fairly complete list. Most of them have been in Parkinson's disease because it's one of the top two neurodegenerative disorders in humans. Most of them have used adeno-associated virus as the vector, or AAV as the vector. And we've delivered various genes to do various things. We've learned a lot of lessons along the way in doing these trials. We've been fortunate enough to be a part of the majority of these trials and their various iterations and phases. And what I want to do today is talk about lessons that we've learned along the way. And one of the big lessons we've learned, and I'm a surgeon, so I tend to focus on delivery, is delivery. So you can have the best therapeutic idea, you can have the best therapeutic agent on the planet, but if it's not getting to the right place in the right way, it's not going to work. And we like to say the three most important things about biologic treatments of neurodegenerative disorders, it's like real estate. The three most important things are location, location, and location. And this is it's an example of where we started in the early 2000s. This was a trial using a traditional stereotactic frame. It's still a device that's widely used today. Anyone that spent any time in a lab will recognize this is just a straight old Hamilton syringe. In this case, it's loaded with AAV, carrying a gene for a growth factor, and we're just doing hand injections to deliver this into a brain target. And we're doing it in a blind fashion. So we obviously can't see inside the brain when we're in a traditional operating room session or environment like this. And so what you have to do is you have to make sure that you're covering the intended target. In this case, it was the putamen. And you can see this is a fairly complicated surgical plan. This is 4 trajectories on each side of the brain, so 8 total. And we have to make multiple deposits along each of these trajectories to try to cover the intended target. And this is invasive, and it has a high potential for error. Error in setting up a stereotactic frame coordinate, error in transposing something. There's just a lot of moving parts here, literally. And, we did a phase 2 study of this particular growth factor. This was a substance called nurturin, which is akin to GDNF. It's supposed to promote survival of neurons, and we delivered it to the putamen of patients with Parkinson's. Phase 1 study looked great. Phase 2 study, which was a sham-controlled double-blind study, showed no difference between the sham group and the treatment group. Now, why is this? This is a lot of money. It's a lot of time. It's putting patients in harm's way. And phase 2 was not positive. And why is that? And how do we avoid this? And we thought a lot about this study because it was really one of the first to go to phase 2. And the results were not what we saw in phase 1. And so there's a couple of possibilities. There's a very strong placebo effect in Parkinson's disease. Maybe that was at play. Was the study design not good? We followed these patients for 12 months. Maybe it should have been longer. Arguments were made that we were targeting a system that was already quite degenerated in Parkinson's disease, so maybe there was just too much neural degeneration. I, again, tend to think about things in terms of delivery, and we wondered if our delivery was really adequate and really recapitulated what was done in the preclinical large animal studies. And there were 2 of these patients that died unrelated to their participation in the study, and we were fortunate enough to be able to examine their brains on immunohistochemistry. And this is an example of what we saw. This is one of the 2 patients. And we thought, based on this delivery strategy, we were going to get about close to 40 to 50% coverage of the putamen, which we believed was necessary to be able to see a clinical effect. And what we saw were these little hotspots of gene expression right along the cannula tracts. And if you look at the total volume of putamen transduced by the vector in these 2 patients, it was quite similar, and it was 14%. So way under what we really needed to accomplish to see a clinical effect. So we started to rethink delivery. And one of the things we did was to start to move towards this concept of conviction enhanced delivery, or CED. So CED is a way of delivering a fluid using a pump to deliver a constant pressure through the system. And when we do a hand injection with a Hamilton syringe, what we're really doing is bulk flow. We are delivering a small amount of vector that's in a high concentration, and we're relying on diffusion to spread this into the surrounding tissue. The problem with that is the brain is not a very good sponge, and this diffusion effect really only gets you distribution about maybe 3 millimeters around the site of infusion. On the other hand, convection enhanced delivery uses a constant pressure head to push the vector or the fluid through the interstitial space, and it gets you a much larger, much broader volume of distribution. The other thing we learned was that cylindrical cannula designs are not very good because they're prone to reflux. So on your left is a traditional cylindrical cannula. It's the same diameter along its entire length. when you start to do an infusion, you can get reflux up and around the cannula because that can become the path of least resistance. This is particularly true if you put a cannula in the brain and it gets jiggled or jostled, or the brain gets jiggled or jostled, or the patient is moved. It sort of breaks that little interface between the cannula and the brain parenchyma, and you can get reflux. A stepped cannula design, on the other hand, has these small little steps. We started square steps and moved to sort of more rounded steps. These steps will resist reflux, and it keeps more of the infusate in the intended target. If you increase the infusion rates, you will eventually overcome that and can start to get reflux, which is why we put a second step in these cannulas. And so these two-step cannula designs really help keep the vector where it's intended. The other thing we started to think about is a different way of doing stereotaxy. Traditional stereotactic techniques, you can't see what's happening in the brain in real time. In about 2004, we started to tinker with the idea of doing device placement in humans using a real-time MR guidance. So this is MRI scanners that are located in radiology. So one common misconception about this technique is that you have to have a fancy intraoperative specialized operating room setup, and that is not the case. So all of these procedures that we initially did are done in regular 1.5 or 3 Tesla scanners in the radiology department. There's a drape that allows you to have a sterile field, and it allows you to place devices in the brain and monitor what's happening. And we've used this primarily for deep brain stimulation. Other groups are now using it quite broadly for things like laser ablation. Well, it's perfect for drug delivery. And one of my partners in San Francisco, Dr. Bankovich, is really one of the fathers of modern gene therapy, along with others. Chris took the ClearPoint system, which we had developed for human use, and used it to start doing gene therapy infusions in non-human primates. And Chris came up with a very good idea. He co-infuses the vector with gadateridol. Gadateridol is a gadolinium-based contrast agent, and it allows you to see the infusion in real time. And Mark Richardson, who's now at Mass General, when Mark was a resident many years ago in Chris's lab, he did a very nice study showing that if you use adeno-associated virus, and this is specifically AAV2, and you co-infuse it with gadateridol, the area of contrast enhancement, which you can see in the MR images on this figure, correlate almost exactly 1-to-1 with the area of actual vector transduction. So if you're using AAV2 in this particular instance, what you see is what you get. Now, there's a caveat. If you're going to use a different vector than AAV, if you're going to use lentivirus, for example, you would need to do a study to sort of show this. But for AAV, and particularly serotype 2, this is a very, very powerful technique. And so we started to think about doing this way of delivering gene therapy in people. And so this is an example of the setup. So there's an infusion pump that's not sterile. It's loaded with a syringe that is got viral vector in it. There's an infusion line that runs onto the sterile field and then in through a cannula, a step design cannula called the Smart Flow cannula that is made by ClearPoint Neuro. It's ceramic, so it's MR compatible. And this is what you see. So this is bilateral simultaneous infusion. In this case, it's AAV carrying a gene for amino acid decarboxylase to the putamen in real time. Now, this is a bunch of images that are sped up. This looks really quick. This is about 2 to 3 hours worth of infusion time for this particular study. But you can see we're doing bilateral simultaneous infusions to the putamen. And it turns out that if you can see what's happening during these infusions, it's very helpful. This was our phase 1 study. This was 15 patients. 3 different cohorts of increasing dose and volume. And this was the most interesting study I've been involved with thus far, because we started to use this technique and we started to learn so much about what was happening during these infusions that we had to really radically rethink our delivery approach in the middle of the trial. And I'll show you some examples. So one of the things that Chris noticed in the non-human primates is this concept of perivascular spread. So basal ganglia targets like the putamen, this applies to the thalamus, caudate, any of the structures that are in these deep nuclei, they have vessels that run through them. They have a fairly rich blood supply. And these blood vessels have a small CSF space that's surrounding them. So you have this blood vessel that's pulsing, and it's pulsing inside a little tube of fluid, and that becomes a very effective pump that can carry infusate away from your intended target. So we'll show you a simple example first. On your left, you can see there's a cannula that's coming down into the putamen on your left. We're going to start an infusion. It's going to start off reasonably well, and then fairly quickly, you're going to see this white streak that's heading up. It's heading up to the caudate, in fact. So this is vector that is being carried away from the intended target around a blood vessel. This is not intravascular spread. This is outside or perivascular spread. So in this particular example, this is not dangerous. It's not going to be harmful to the patient. But it's also not going to be helpful. If you're losing vector from the intended target, your chance of seeing a clinical effect goes down. Here's another example on your right. You can almost see the problem already. You can see a little dark streak that's going around the the sort of lateral aspect of that putamen on the left. That's a large vessel. We're going to start an infusion, and then fairly quickly, the vector is going to spread around that vessel and all over the place. So this is one reason why we only got 14% coverage in that first study that I showed you when we were doing blind infusions. We were expecting to get 40%, we got 14%. The other issue is reflux. We knew reflux was a thing. We knew this could happen. And indeed, we did see it. So again, back on your left, there's a putaminal infusion, and that orange line is at the top end of the putamen. So anything above that orange line is going to be vector expression that's not going to be helpful for this subject. So the infusion is going to start reasonably well. We're going to start to get reflux. And once you get reflux, it's game over. Fluid is always going to follow the path of least resistance. The path through the intraparenchymal space with CED there is resistance to that. So if you get an opening of a place for vector to go that's a lower resistance, like up and around the cannula, it's going to take that path. And I'm going to talk a little bit about how we changed our approaches to try to come up with a way to try to circumvent these things that are causing off-target delivery for us. So one of them is what we call a stacked infusion strategy. So we used to go to the middle of a target and try to fill it up from the middle. And this was based on what we now know is an erroneous way of thinking, that if you start an infusion in the middle of a brain region, you're going to fill it up from the center. The fluid is going to behave well, and it's going to just be this big ball that's going to get bigger and bigger and bigger and cover your intended target. We now know from these videos and from what we saw intraoperatively, that's not the case. So we started doing what we call stacked infusions. So we would start an infusion dorsally. Once we got a good infusion ball, we would then push the cannula deeper, and we would try to bury that second step into that first ball of infusion, if you will. And that sort of acts like a cork. and it helps resist reflux. And then we do a deeper infusion. So this can help with reflux. It also is a way of combating perivascular spread. If you start to get perivascular spread, the only way to overcome that is to move the tip of the cannula away from that vessel to stop the spread. The problem is convection enhanced delivery depends on the tip of the cannula being up against the brain parenchyma. So it's pushing fluid directly through the interstitial space. If you withdraw the cannula, you're then going to be delivering into a hollow space that the cannula has created in the brain, and it reduces dramatically the efficiency of CED. So you want to start proximally and advance. And this is our initial strategy, which was a stacked infusion. This is what it looks like in a real subject. So on your left, we're going to start a dorsal infusion. Once it gets to a reasonable size, we're going to advance the cannula, and we're going to do a deep infusion. And the second step is fairly visible on these videos. So you can see it looks like the cannula is ending above the putamen. That's really where the second step is. The cannula gets so thin beyond that, you can't see it. So you can see that little second step above the caudate or putamen, then it goes down, and then we do the deep infusion. So that's what we call a stacked technique. We then started to think about a more efficient way of doing this, and this is what we call a progressive infusion. So this is starting an infusion and then slowly advancing the cannula as we go. So this can help both resist reflux as well as help you manage perivascular spread. If you're proximal in the target and there's not a lot of perivascular spread, you can fill up that proximal part of the target. Once you've got comfort with your proximal coverage, you can go deeper, or if you're getting perivascular loss, you can just advance, get more coverage deeper. So you can vary the infusion rate and the position of the cannula to tailor the infusion to maximize delivery to the intended target. Here's an example in a subject, your right side this time. We're going to start an infusion. It's going to just start to reflux a little bit right here, and then we're going to slowly advance. It'll push that second step into the dorsal part of this infusion ball, which will resist reflux, and it gives you a very nice, very pretty infusion. So we varied our technique significantly in this study. And I told you it was a dose escalation trial. It was a phase 1 study. So we started with 450 microliters. In cohort 2, we jumped up to 900 microliters. So it's not surprising that we got better coverage in cohort 2. But the only difference between cohort 2 and cohort 3 was actually our delivery technique. So we went from middle of the target infusions in cohort 1 to stacked infusions in cohort 2 to progressive and stacked infusions in cohort 3. This is looking at the total coverage of the putamen. For this particular study, we were most interested in getting coverage of the posterior part of the putamen. And based on preclinical NHP studies, we knew that we needed to get about 35% coverage of the putamen to see a clinical effect with this particular therapeutic. This was an enzyme replacement strategy. And you can see we were well below that in cohort 1. Cohort 2, we were right there, and cohort 3, we were definitely above, particularly in the posterior portion of the putamen, which is really our intended target. So if you look at clinical outcomes data for these patients, the cohort 1 in gray really didn't have any improvement, which you would expect because coverage was below that 35% threshold. But cohorts 2 and 3, we did see clinical effects. We also looked non-invasively. We used PET imaging to look at basically dopamine activity in this portion of the putamen. And as the coverage improved with each successive cohort, we saw an increase in the PET signal. At the same time, if this enzyme strategy works, patients will need to take less medications over time. And we saw a greater increase in medication, or I'm sorry, decrease in medication use as the cohorts progressed. So these we think represent a coverage or dose-dependent effect in this particular trial. Now, there's one huge caveat. This is an open label study, and you really don't know whether these effects hold true until you expose this to the rigors of a placebo-controlled or sham surgery-controlled trial. The other thing that we learned, and this was also Mark Richardson's work while he was in Chris's lab, is how to think about dosing. And Mark wrote a very nice paper that talks about this concept of the VD-VI ratio. The volume of distribution that you get in the brain is related to the volume that you put in. And when these CED infusions are sort of as ideal as they can be, it's about a 3-to-1 ratio. So if you want to cover about 1,500 cubic millimeters of a particular target, in our case, the putamen, usually, you have to put about 500 microliters of vector in to achieve that. Now, I just told you that, and just showed you that these infusions are never ideal, right? So even using these strategies with MR guidance, using a step cannula, using these infusion techniques like progressive delivery or stacked infusions, you are still going to get some reflux, or you're still going to get some perivascular spread. So a more typical VD-VI ratio is closer to 2-to-1. And when we do these human trials, we're usually living somewhere between these two lines. So this is a very powerful tool. We can use this ratio, and we can use it retrospectively to look at studies that we've done in the past. We can also use this prospectively to try to plan how much volume do we think we need to deliver for a particular target. Now, again, I'm showing data that's related to putamen. If you look at the vertical axis, the average human putamen, the volume is about 4,000 cubic millimeters. If you're thinking about using a therapeutic for another target, you just simply change the vertical axis based on the volume of your particular target of interest. But if you look at the early studies that we did, we were living down in the lower left part of this line. These are coverages that are in the low to mid-teens or single digits. And this is exactly what those two patients that died in the nurturing study showed us. We were right at about 14% coverage. So we don't want to be down here. We want to be up around 50% or more. So in the AADC study that I just showed you, we started with 450 microliters and worked our way up to 900 microliters. And this was based on a change during the study where the first cohort, we clearly were not getting the coverage that we wanted using 450 microliters. We went to the agency and said, look, we need to give more. It appeared to be safe and well tolerated. So we talked them up to 900 microliters for those second two cohorts. We started to also think about not only pushing the volume, but also thinking about efficiency. And we've always used these sort of transfrontal approaches to get to the basal ganglia, things like the putamen or the caudates or the thalamus. We do this because we know it's a safe approach, and it's familiar to surgeons. This is the approach that we take when we put in electrodes for deep brain stimulation, for example. But a lot of these structures, particularly the putamen, it's an elongated structure in the anterior posterior dimension. And a much better way to think about covering it is to come from the back. This would allow you to potentially get equal or better coverage with only one cannula pass instead of two. And so with our more recent studies, we've moved to this technique. So this is a patient in the prone position. We're going to mount two ClearPoint Neuro smart frames in the back of the head. We've started moving towards these percutaneously mounted frames, so you no longer actually have to make an incision. These mount sort of percutaneously with a series of screws through the skin. The frame sort of sits above the scalp, much like an oil derrick, if you will. You align the device to the intended target. There's a twist drill that we use to make about a 4.5 millimeter burr hole. You can see the infusion cannulas on the right. And this is what it looks like. So this is bilateral simultaneous coverage of the putamen, this time with a posterior approach. And we did a phase 1 study looking at this approach and found that we got better coverage, significantly better coverage with a single cannula pass. And because it's more efficient, it's a shorter procedure time, which is an important consideration. And this is what the incisions look like. And a lot of this was based on our epilepsy colleagues who have been doing posterior approaches to the temporal lobe to do ablations for epilepsy now for the better part of a decade with a very good safety profile. The other thing we did with this posterior approach is that we really sort of talked the agency up to allowing a dose that we felt would give us coverage in the putamen. And we talked them up to a volume of 1,800 microliters. So this is an interesting concept. I mean, what you want to do with biologic agents like this is to give patient-specific dosing. Some people have big putamens, some people have small putamens. You'd like to give just enough to cover the intended target, not more than you need to, but you don't want to underdose people if they have a larger target. And the FDA has traditionally wanted to know what's your dose, and that's going to be a fixed dose from subject to subject. And by using this concept of delivering up to 1,800 microliters, this is actually a volume that you can't achieve in a significant number of people. Their putamens aren't big enough to accommodate that. And so what this really allowed us to do for the first time was really do patient-specific dosing. We're going to give up to a max of 1,800 microliters, but if in the opinion of the study surgeon, the coverage is greater than X% and it looks like the coverage is adequate, and if it's only at 1,400 or 1,650 microliters, we're going to stop. And I think this is an important concept because I don't think you can think about biologics, particularly gene therapy, like a traditional drug where there's a dose that you're going to give someone orally. So with this larger volume, up to 1,800 microliters, and this posterior approach, we're consistently getting coverages in the posterior portion of the putamen that are over 75%, which is really what we want to see when we're delivering agents like this. So we're very excited about the future of MR-guided delivery. Fortunately, now we have these tools and technologies to do this. Do it reasonably, do it safely. And I think the future is very, very bright for biologics. I think the next exciting chapter is going to be cell transplantation and cell delivery. Delivering cells is not as complicated as delivering a fluid, but at the same time, you need to make sure it's going in the right place. And so we're very excited about the future for both gene therapy, for cell delivery, and for other biologics. And so my advice is stay tuned. I think there's a lot of exciting time coming ahead. All right, I will stop sharing. And we tried to leave some time at the end.
Yes, thank you, Dr. Larson. Looks like we have a few questions already. So in your experience, how did the preclinical NHP studies of convection-enhanced delivery of the vector inform your clinical study delivery parameters?
Yeah, so the preclinical work is obviously hugely important from a tox standpoint, from an efficacy standpoint, and that's how we've traditionally thought about NHP study. And really, in the 2000s, you know, the delivery was really sort of well, we're not, we're just going to use a frame and we're going to stick it in the head, and the primate's brain size is this, and we're going to just the human size it's a factor of X, and so we're just going to scale it up. You have to be way more sophisticated than that. So you have to consider your target volume in the NHP relative to the target volume in a human. You can't just simply say, well, the primate brain is this and the human brain is that, and it's just a matter of whatever X. It's the target, and the relative size of these targets in an NHP, for example, they're different. I mean, primates have a relatively small cortical volume relative to humans. Some of the basoganglia targets are relatively different sizes in humans versus NHPs. So you have to be more sophisticated about it. And I think this concept of the VD-VI ratio is actually very useful when planning a therapeutic, if it's a drug delivery therapeutic. Again, the caveat there is the work that's been done has used AAV. So if you're going to use a different vector, for example, AAV can't carry a very large payload. Lentivirus is better if you're carrying a large payload, if it's a multi-gene strategy, for example. And to my knowledge, this sort of work correlating what you see is what you get. Does the VD-VI ratio hold true for lentivirus? I don't know if that work's been done. But I think it's a very useful strategy and tool. So I think people are now getting more sophisticated about thinking about delivery during the NHP work or phase, as in addition to thinking about tox, efficacy, and the other things.
Great, and I believe this is referring to the volume infused with the volume distributed as well. Is there any possible estimates on volumes for delivering stem cells, like your 3-to-1 ratio, 2-to-1 ratio? Any ideas on that?
Yeah, so cells are different, and the considerations for delivering cells are different. Viral vector is really suspended in a fluid. You're really delivering a fluid, and so cells are suspended, but you're delivering a solid, basically, that's suspended in fluid. So cells are different. You have to, and there are other considerations with cells. We didn't really talk about that a lot today, partly because we're in a sort of a resurgence of use of cells of various types for biologic disorders, or as a biologic strategy for neurodegenerative disorders. But these concepts of being able to see where you're delivering, making sure that you're not off target, I think can be very useful for cells as well. But the VD-VI ratio doesn't really apply because you're not using CED, and you're not really delivering a fluid per se.
And it looks like, can you comment on the safety profile of the gadolinium tracer for direct infusion into the brain? It is my understanding that GAD is FDA approved for systemic administration use. Any thoughts on that?
Yeah, so this was a bit of controversy when we started doing this. There are a few papers, two specifically, that raised concerns about gadolinium and delivering it directly to the brain. So one of these studies was an animal study. It was basically giving intravenous GAD at a rate and frequency that would be equivalent of a human getting multiple gadolinium enhanced MRI scans every day for weeks at a time. And there were findings in some of these animals that there might be traces of gadolinium in the brain itself. There was actually no real evidence that there was a clinical or a behavioral effect related to that. But many people have sort of pointed to studies like this. So you can't give this intraparenchymally because, if you give a ton of it IV over and over and over again, it causes changes on imaging, but no one has shown that that's actually bad. And they weren't really intraparenchymal studies. This was a controversy at the time we started doing this. We have not experienced any deleterious effects that are related to co-infusing with gadateridol in humans. And there are dozens of people that have now received that in clinical trials and been very closely followed. So we don't have an issue with it. And I think that the concerns that have been raised about it are based on studies that are not really applicable to what we're doing.
And then are there any concerns with these high volume infusions having a higher risk of lesions that may show up in acute or chronic time frame?
Yeah, so this is another common question that we get. And this is why early on in our experience, we used very, very low volumes. Some of these early studies, they were, 30 microliters, 50 microliters to these targets. And the other concern was the flow rate. So there's this a perception that, well, you can't deliver quicker than 1 microliter per minute, or you're going to cause parenchymal tissue injury. So Chris and many others, Marina Emborg and many other people in the NHP world, Jeff Cowardover, have done very high volumes in NHPs and done very close histological studies after the animals have been sacrificed. And you just simply don't see tissue damage, even with these larger volumes. You also don't see tissue damage at the tip of a cannula when you're infusing up to 15, 20, 30 microliters per minute. So in humans, we have gone up to 15 microliters per minute. And the reason, honestly, that we haven't gone more than that is when you start to infuse at that rate, because these MR sequences, MR images, these that we're using to evaluate the infusion, they take about 2.5 minutes to acquire that image. So you're infusing, the infusion's happening, but you're looking at snapshots that are like 2.5, 3 minutes apart from each other. And if you're going much faster than 15 microliters per minute, things are happening so fast that you're not adjusting the cannula position, for example, adequately if you start to get reflux or if you start to get perivascular spread. But there's simply no evidence in NHPs or humans that using these larger volumes at these higher infusion rates are deleterious. They're theoretical concerns that have just not been shown to really be true in real world application.
And in terms of preoperative planning exercises, do you typically do any sort of preoperative planning exercises for these CED procedures? And if so, what type of software tools would be helpful for planning out the eventual infusion?
Pre-op planning exercise like pull-ups, sit-ups. I do some crunches right before. So that's a good question. So we will frequently and really always pre-plan these trajectories prior to the day. All this work that we've been talking about has been happening in the context of a human clinical trial. So we take these things very seriously. So we'll get high resolution MR scans of the subjects weeks ahead of time. We will sort of pre-plan the trajectory. It's usually shared with a committee. So there'll be a committee of surgeons that will sort of review and give feedback about, I think this is a good trajectory, or maybe have you thought about tweaking it this way or that way? The platforms that you can do this on, it's really anything. You can do it with ClearPoint. So you can, if you're using ClearPoint as the platform, you can do it on a ClearPoint laptop, and then you can screen share that with people outside your institution. HIPAA laws apply for the lawyers yell at me. You can do it on BrainLab. You can do it on a Stealth. All of these sort of planning workstations allow you to plan a trajectory from point A to point B. Now, what you can't pre-plan is what's going to actually happen during the infusion. So, how the infusion progresses, what flow rate are we going to start with? When are we going to advance the cannula? When are we going to start to ramp up the infusion rate? To what rate are we going to go up to? All of that happens on the fly live during the procedure, and it's based on MR feedback. So you can plan the trajectory ahead of time, and we always do that. But the actual infusion, the whole point of this is that you don't know what's going to happen. And so you have to do that sort of on the fly during the procedure.
Awesome. And then with regards to patient-specific dosing, how did you manage offering a patient-specific dose volume when different dose volumes change dose concentration from patient to patient? And did this, would this impact efficacy?
So for a phase 1 study, we didn't do that, right? So the phase 1 studies, phase 1 trials are safety and tolerability trials, and you're usually trying, it's usually a dose escalation strategy. So you're giving a certain amount of vector genomes or a certain amount of volume, and then you step that up. And for those studies, when you're trying to determine, what is the safe dose, so to speak, it's hard to do that. What we learned in our trial, we thought, okay, well, we gave 150 microliters in the original phase 1 study with traditional stereotactic techniques. Now we're moving to MR. We believe we can get more volume in. We're going to go to 450. We thought, 450 is a lot. We did the study and we found that we were easily delivering 450 and could deliver more. And the argument we use for going higher is, look, we're putting subjects in harm's way. These procedures do have risk. The risk is fairly low, but it's risk nonetheless. These, in the case of Parkinson's disease, these patients have, a viable alternative therapy, which is deep brain stimulation, which reliably makes them better. So, we need to make sure that we're not knowingly underdosing subjects. We want to, we need to give them a chance to have a clinical effect. So that's how we sort of talked up to these higher volumes. 1800 microliters, again, it's not that we went to the agency and said, we want to do patient-specific dosing. The agency still said, what's your dose? What are you going to give? And what we did is we basically said we were going to give a volume that's not achievable in everybody. So some patients you can give 1800, but some you can't. And the key is, they let us say, well, if you think the coverage is adequate, you can stop sooner than that. So it's not, we're trying to move towards patient-specific dosing, but for the time being, the FDA still wants to know what is your high dose, what's your dose going to be, and you have to come up with a number.
Awesome. And it looks like, are there any other potential complications of doing these blind infusions besides the potential for poor infusion coverage?
That's a good question. I mean, the surgical risks are actually quite similar. You're putting a cannula in the brain, so there's a small, we usually quote a 1% risk of a symptomatic hemorrhage doing that, just putting a device in the head. If you're putting a cannula in with a traditional stereotactic frame or putting it in with MR guidance and ClearPoint, for example, it's that risk exists for both. There's theoretically a risk of infection because you're opening up the skin. I have to say, in all the studies that we did, none of the sites ever had an infection. The infection rate is just very, very low. So the short answer is no. From a surgical risk profile, there's not really a significant difference or a difference. I guess the one caveat would be if you do a blind infusion, you can do it really quickly because you're not adjusting what you're doing based on anything. You're just sticking a cannula in, setting a rate if you're using CED, and then just watching the clock. until a certain volume is delivered. You can do that actually quite quickly. You can do that in an hour. If you're doing MR-guided infusion, the whole point is that you're changing what you're doing based on what you're seeing, and one case might go more quickly if you can ramp the volume up quickly. If you're getting more reflux or you're getting other factors, perivascular spread, you might slow down a little bit, or you might move the cannula more but keep the infusion rate down. So the times will vary. Longer procedure times can mean higher risk of things like DVT formation, for example. So if you have a procedure that you can do in an hour versus one that takes 6 or 7 hours, there's theoretically a risk difference there. But from a pure surgical procedure standpoint, there's no difference.
And having that real-time visualization information, I mean, how many times would you say that you actually made an adjustment based off the information that you had, whether it was reflux, perivascular spread, where you actually moved the cannula or made some sort of change real time to ultimately optimize that infusion?
Every single time.
Every single time. Wow.
Every single time.
With the regarding the prone positioning for the posterior approach, are there any concerns with anesthesia or any modifications that you needed, to do with the workflow? I understand there might be some concern with that positioning technique.
Yeah, so I actually had reservations about the prone procedure myself. It's a challenge from a positioning standpoint. Anesthesia is not super thrilled with it. I mean, anesthesia does prone positions in the regular operating room all the time. The difference is, in the regular operating room, they have ready access to the airway. In the scanner, that they don't. However, I reminded them that when we're supine, they also don't have ready access to the airway when we're in the scanner. So once they went, okay, well, it's not really that different. It was not a big deal. So from an anesthetic standpoint, it's really no different from an anesthesia standpoint, being supine or prone. You do have to be careful about what we call bore collision. So the cannulas are coming out of the back of the head. So they're coming out at a close to a right angle to the bore of the scanner. And you don't want the cannulas to hit the bore of the scanner. So we generally elevate the thorax and really flex the head quite significantly. That brings the angle of the cannulas away from the bore of the scanner itself. So there are some considerations doing the prone position. There's a very nice head holder now that you can sort of apply. It's sort of a half ring that you can apply to the patient's head with them supine. And then when you turn them prone, that ring sort of goes into a cradle. And that really takes a lot of the stress out of positioning them. For me, that was the hardest thing. If the head holder is on the gantry, the MR table, and you're turning the patient into it, you're pinning sort of with the patient already in the prone position, which can be a little stress inducing. So that head holder has gone a long way towards simplifying things.
Great. And I think, if there are any other questions, please submit them. But it looks like we're at the top of our time here. Dr. Larson, can't thank you enough for being here today. This was great. And I think I speak for everyone when I say, thank you for sharing your experiences and how you optimize this workflow. I definitely learned a lot, and I'm sure we all did.
Great. Thanks for having me. I appreciate the time.